Hold on. All right, we're live, but we're going to wait a couple of minutes for people to join up. We are with Dr. Tatiana from the Baton Rouge Clinic, physician of infectious diseases. Doc, get comfortable. We'll start in about 5 minutes.
Okay, sounds great.
Let's see. And I'll keep an eye on Facebook in case people have questions.
Okay.
All right. Hold on. Let me turn my volume down. It's a very nice hat, Doc. It's a very nice hat.
Thank you, thank you. Courtesy of Geaux Rouge.
You know, if it wasn't tone deaf of me, I would get the hat made into a mask, but I fear that would be perceived or taken the wrong way. And I don't want to be that guy. I don't want to be that guy. Although you'd be very proud of me. I finally, and I was resisting, I finally got both medical grade masks as well as some custom made masks that I'm actually starting to wear and get used to. It's a little weird. But you know, it's interesting, and we got a couple minutes before we start. It's interesting because certain restaurants, shout out to Churchill's is selling in a pop-up form masks, disinfectants, toilet paper. So restaurants are starting to do kind of like because they have ties to distributors, they are starting to sell that. Yeah. So I felt like a boss yesterday. I bought toilet paper. Although my wife criticized me because it was single ply and not like special double. Yeah. She said this morning, God bless Shannon. Shannon said, I don't want to use single ply unless I have to. Adrian, is hot dog a sandwich? No, a hot dog is not a sandwich.
Did she post that?
Adrian posted. Adrian,
Busicus.
I don't know if you.
Sorry.
Yes. Do you know her?
Hearing you.
Yeah. So Adrian, it is not I am a hot dog enthusiast. It is not a sandwich. I repeat, not a sandwich.
Adrian is part of group 3.
Awesome. I love me some group 3. Group 3 is a great group. Have y'all still been able to run a little bit with everything that's going on, or
not in big groups?
Okay.
Sometimes like 2 or 3 of us will get together to run, but we're good, and we still, we manage to stay apart. But it's still nice to just kind of see our people.
So it's about that time, guys. This is attorney Franz Borghardt with Geaux Rouge. I'm sitting with Dr. Tatiana from the Baton Rouge Clinic. She is a physician of infectious diseases. This is part 2 of our webinar series with her. I'm going to keep asking her to talk to me as long as she's willing. We've got some stuff that we're going to cover that we probably covered last time. We've got some new stuff that we're going to update you guys on. I thought it'd be good. A lot of people are doing medical commentary right now that are not physicians of infectious diseases. So I thought it would be good to have the doc on. If you're listening in Facebook world, I am keeping an eye. I'm keeping an eye on the live stream. So if you have valid questions for the seminar, for example, Holly Marie asked, what category does a hot dog fit into? It is not a sandwich. It's its own unique creation. So that would be an example, not a medical related question, but that would be an example of a question that I can pose to the doc. So Doc, how are things going? How's the family?
Family's good, a little stir crazy, but we're surviving. I know everybody's in the same boat, so
yeah. So I want to start off with masks. We talked a little bit about masks last time. If you're someone like me who's not in the medical industry, who's not first line, front line, not dealing with sick patients. Talk a little bit about what we should be doing, people like me, in terms of covering our mouths, maybe wearing gloves. Is that something we should be doing at this point? And talk a little bit about what will work for the purposes of going to the grocery store or going to get gas or whatnot.
That's a great question. So there's different kinds of masks. And so there are some masks that I do hope that people that are not in the medical field are reserving for those that are working kind of front line. So, and those are the N95, and they're really considered respirators. They're not considered like routine face mask. And I think I showed y'all an example of one last time. I can't remember if I did or not. So this is like a respirator that we would use in the hospital taking care of COVID patients. So those I would encourage people out in the community, unless you are in the healthcare field or you're actively dealing with COVID patients, reserve those for the healthcare workers. Now, regular mask, which I think I have one back here. Hold on, let me see if I can get it. Regular masks like this, this is what we're encouraging the general public to wear when they go out. And I realize that not everybody can get their hands on what's considered like a medical grade mask. And so I've seen a lot of people making them from fabric and really cute masks and different patterns. And I think it's great. So really what the recommendation is now, again, different masks serve different purposes. A respirator like this is going to be to protect the healthcare worker from contracting the virus because of just the nature of the mask. What it's made from, how thick it is, it doesn't allow particles in, or certain size particles in. Whereas when you're talking about a regular mask like this, or even a fabric mask that you make at home, or even a scarf or a bandana, anything that you could use, you don't necessarily have to have access to something like this. The purpose of this is so that your germs aren't going elsewhere. And so because we're doing all of these things to try to minimize the spread of COVID, with social distancing and home isolation and, all those things, wearing masks when you go out helps, because if you potentially have it, even though you may not be symptomatic from it, we do know that people can shed the virus even being asymptomatic or without symptoms. And so the goal and the purpose is, if everybody goes out and wears a mask, then you're doing your part to protect the other people in the community. And so I think there is very much a role for us to be wearing these now. At first, my concern was that I was afraid people were going to go out and try to find these masks, and then, healthcare workers, because there was a shortage of them. But people are making these, I've seen a lot of people like selling them and then, using the money for different nonprofits or different organizations around town, which I think is awesome. But so yeah, absolutely. I think masks are an important thing that we can do as members of the community to kind of help reduce the spread in the community.
So a follow-up question from your friend, Adrian. Is it okay to keep reusing that type of mask, or should we look into getting one that we can wash or be cleaned? I have heard some people are using disinfectants to kind of spray on their masks before they use it, let it dry a little bit. So anything you got on that front would be very helpful. And Adrian, thank you for the question.
So with regards to these, when we were having a shortage of these, so I was having to reuse mine a fair amount. Now that people are making fabric masks, I think going that route might actually be more beneficial, because you can easily throw it in the wash, wash it, and then have it fresh. What we don't know is what happens to if things break down when you spray it with disinfectant. This is not made of a fabric. It's it's a little bit more porous. If it gets wet, it might become soggy, and then it might not serve the purpose. And so there's, and I kind of looked into this earlier when we were really having a shortage of N95s, whether or not there was any data to support, spraying it down. And there really wasn't.
Okay.
I mean, there's data to use like UV light and certain things to disinfect. So I know different hospitals have different equipment now that they're trying to use to allow these to be used more than once. But you know, a person that's not working in a hospital is not going to have access to that type of equipment and things. So I think for the people in the community, probably the easiest thing would be a fabric mask or a bandana, something you can throw in the wash, clean it, and then, you know, reuse it.
Tim, that should answer Tim's question about what should common folks be using. Kimberly has a question. How long are masks going to be needed by the community? That's a tricky one, right?
That is a tricky one. And I don't know that we have the answer to that. You know, we are seeing, you know, we've talked about the whole reason that we've kind of done the stay-at-home orders and the social distancing and things like that was because we're trying to flatten the curve and we're trying to decrease the number of cases. We realize that they're not going to go to zero. We will be living with this for a while, but what we want is we want to steadily decrease the amounts to where they're much more manageable. And so I think at some point there will come a time when we're not going to be expected to continue to wear masks. I just don't know when that's going to be. I think we're going to have to see a pretty consistent downward trend in our numbers before we get to that point. And I mean, I don't know. I'll let you finish. I was going to bring something to tie something into it, but
well, you go right ahead.
Okay.
Tie it in.
So since we're on the subject of talking about when we will be able to stop wearing masks, one of the things that might lead to that is if we know that there are several people in the community that are already immune to the virus, then that might be another kind of trigger point for us to kind of further start to open up the economy and kind of try to get back to normal life. So right now, all the testing that we've been focusing on has been on actual COVID PCR testing, which is detecting the virus. So when someone comes in and they're symptomatic, we're doing these tests because we want to detect the virus, see if they have it. Well, now that we're, you know, several weeks into this whole pandemic, at some point, we're going to probably want to switch focus and start checking people to see if they've developed the antibodies. So maybe someone who didn't have the typical symptoms, or maybe they did have the symptoms, but they never got tested and they want to see if they are immune to it. And so I think those numbers are going to have to ramp up too, because again, you know, and I mentioned this last time that we talked, this is a novel virus. We've never experienced this before. We're learning about this virus every day. Things are changing. We're getting new information. You know, we're getting new data from clinical trials and all sorts of different things. And so as we learn more, I think what we're going to see is our focus shifting from not just testing those that are having symptoms, but then testing people who think they may have had it or maybe just want to see if they are immune to it. And all those numbers are going to really help determine how we proceed moving forward.
So that leads me into another question. Can you talk a little bit about antibody testing, where we are? And then you mentioned the word immune.
Yes.
I know what immunity means, both in a legal world, and I think I know what it means in a medical world. But the question I keep getting asked is, what do we know at this point about if I catch it, I survive it, I get over it, can I catch it again? And if I catch it again, is it going to be as severe? Those are the questions I keep getting asked. So talk a little bit about antibodies and immunity.
Okay. So one of the, and I'm going to try to break it down to make this as simplistic as possible. So people who are not in the medical field can fully understand it. So whenever someone contracts an infectious disease of any kind, you know, virus, bacterial, whatever, your body's response is to make antibodies that are essentially going to lead to destruction of whatever is attacking you. Okay. Now, these antibodies are present in the blood. Now, the blood is kind of, you know, your blood is made of different things. Your blood is made of red blood cells, white blood cells, and then you have plasma, which is kind of the liquid portion of the blood. And so the plasma is really what's rich with all of these antibodies. So usually what happens when someone develops an infection your immune system kicks in. You know, the best way I describe it, and I describe this for when I'm treating HIV positive patients, but you know, what I always tell people is, you know, you have your little soldiers, your front line of defense, and some of those are your cells, some of those are your antibodies. And the whole purpose is to kind of gang up on whatever's attacking you, you know, take care of it and get rid of it. And so whenever you develop an infection, that's what your body's response is. You're going to develop antibodies to protect you from whatever the organism was. So what we should see is if somebody's been infected with COVID, and the timing, and this is where we're still learning some things, and there is some data out there that gives us an idea of like how many days post-infection do we expect to see antibodies present in the blood. So what should happen is when someone's infected with this virus, your immune system kicks in, starts making antibodies to protect yourself against it. Those antibodies should theoretically be there. And I don't know that we know that it'll be there for life, but it will be there for some period of time. And the purpose is that if you do happen to get re-exposed sometime in the future, then you have the antibodies present there to attack it and try to prevent you from having symptoms. And I may have given this example. I don't know if you and I talked about it before, but you know, think about when kids used to get the chickenpox before the chickenpox vaccine was available. You know, back then people used to have chickenpox parties, get their kids together so everybody would just get it, knock it out. And most of the time you didn't see kids become reinfected with the chickenpox because they developed antibodies to it. Same goes with this virus. The thing is, we don't know, again, how long lasting these antibodies are going to be. And there are some case reports and some kind of some cases that were coming. I don't know if it was necessarily here in the US or elsewhere in the world, but of patients who had been infected, recovered, and then tested positive again. Now, my question when I hear that from the, you know, the science brain in me goes, were they symptomatic or did they just happen to retest them and they still had virus present? Because there's kind of a difference. And theoretically, if your immune system is, you know, really active and is not suppressed in any way, theoretically, your immune system should handle re-exposure. But it's not always perfect.
So Janelle asked the question, and this is a good question. Can a person actually be immune without having had the virus? And I'm going to piggyback the question because you mentioned asymptomatic. Can you have the virus and never know that you had the virus?
Yeah. So I don't think that the first question, which was, can you be immune without ever having been infected? And no, you can't, not now. So again, this is different because this is a novel virus. You know, sometimes we can say the flu, for example, you may not get the flu every year, but you get the vaccine every year. And so you have some immunity to the different strains of the flu when it's around, even though you may not have ever been infected with it. Because this is a novel virus and nobody's seen it, you don't have those antibodies present because it's never been seen before. The second question you asked was asymptomatic. So it is possible. We don't know. So we think that kids might be asymptomatic carriers a lot for this virus because we haven't heard too many cases. I mean, kids have gotten sick from it, there's no question, but not to the level that adults and the elderly have. And so what we're seeing is there is a thought that maybe there's been a lot of people out there who may have been infected but didn't show any symptoms. And so do they have the antibodies present?
Right.
So piggyback to the next thing. Okay, go ahead.
No, keep going. Because I was going to ask you about transfer of antibodies using plasma, but you're going to get there at some point anyway.
I'm going to go there next, but I have one more thing before we go there. So the next thing I want to say is the test, because you asked and I kind of like glossed over it. So testing for serologies, it is in the works. The difficulty is with a lot of these things, and we saw it with the testing initially for the virus, is you might have the test, but you may have limited numbers of tests, or you might have limited numbers of supplies to run the test. So even though you may have the machine to do it, there's a lot of other factors that kind of play into it. With a lot of the tests that we run in medicine, they have to be validated. And so the issue comes in, this is a new test, right? We've never seen this before. We've never checked for this antibody before. And so you need to have some way to validate your test to make sure that you're not telling people incorrectly that, oh yeah, you've had, you tested positive for this, so sure, you're protected. But if we don't have a way to, validate that for sure, then, we're giving false information.
And when we say, and not to interrupt you, but when we say validity or valid testing, let's be very specific on what that means from a scientific method standpoint.
From a scientific standpoint is, and I don't want to get into too much of the nitty gritty because then it gets kind of confusing, but in medicine testing, you want things that are specific, but you also want it to be sensitive enough. So sensitive enough to detect what you're looking for, but specific to the one thing that you're testing for. And not every test is 100% sensitive or specific. There's kind of, it's not all black and white. There's a lot of gray. And so when I talk about validity, we want to, in some of the, I guess, one of the best ways I think that we can validate some of these tests is if you have a person that was COVID positive, because you have a COVID positive PCR test, so they had the virus, then use those patients as kind of like your test patients to validate the test, right? Because they should have the antibodies, but they were infected with the virus. Their immune system, if it's working, should be producing those antibodies. And so use their blood to test these, or to validate the test to see if it's truly, a good test or a good platform. So I think that's where we're probably going to be headed soon, rather than just opening it up to people who are asymptomatic, because I think that's where you're going to get into trouble. Right. There's been talk in some of the medical literature that there's a possibility of cross-reactivity with other coronaviruses. Remember, and I don't know if we talked about it last time that I was on with you, coronaviruses as a general rule are not brand new. Coronaviruses have been around for a long time. This particular coronavirus is new. And so, the concern always is, could you potentially have cross-reactivity with the ones that have been around for a long time and then get a false positive and then give that person a false sense of security that they were infected. So moving forward to what you were talking about the plasma, and this, y'all, I'm like, the nerd in me is like super excited about this because we are trying to, here at the Baton Rouge Clinic specifically, we've partnered with Mayo. They're kind of our partner with the general as well. And we are participating in a convalescent plasma program for those patients who have been positive for COVID. So we know that they tested positive. Once they've recovered, and there's a lot of criteria that they have to meet, but once they've recovered and they're far out from their acute illness, having them donate plasma, and then matching them with someone who's ill in the hospital and using the plasma therapy to see if it will help improve outcomes. And so it's part of a clinical trial. I'm super pumped about it because I think we do this kind of therapy for other things. So we've done it for things like Ebola, things that we didn't have a lot of therapies for. So we've done it for like hepatitis B. We've done it for measles when measles was really, really bad in the past. And we've done it for Ebola as well. And so I think this is going to be something else that we can offer our patients. And so I'm super excited about it. And I throw it out there because obviously here at the clinic, we're looking at our patients who've tested positive. We're going to start working on contacting them to see, hey, how are you feeling? Have your symptoms recovered? If so, at some point, would you be interested in participating in this program and being a plasma donor? But I think also people out in the community who maybe don't necessarily have to be a patient of the Baton Rouge Clinic, if they were positive and they want to look into doing this, I think it would be an incredible thing that we can do to help the ill people in our community.
So Holly had a question in that vein. Holly had a question and she had to jump off. So I'll tell her what the answer is.
Okay.
She wanted to know where we are with medicines and medical treatment using medicines.
Okay.
And as a secondary question, good question, not necessarily just treatment, but other medicines that may just help build up the immune system.
Okay. So medicines. The IDSA, which is the Infectious Disease Society of America, they came up with kind of a treatment guideline at the end of last week. And they've been modifying it every day as new information has come out based on clinical trials that have been done. And so it's pretty lengthy. You see, I was kind of reading it.
Fun times. Fun times.
Well, look, for a nerd like me, you get like all excited about this kind of stuff. But there's a lot of things that they're looking into, because I know people have talked about, and President Trump got on and was talking about hydrochloroquine and, you know, the azithromycin, how this was going to be like the big fix for this virus. And so IDSA kind of went in and looked at the data that's available, and there's not a whole lot, looking at things like hydrochloroquine by itself, hydrochloroquine with azithromycin, lopinavir, ritonavir, remdesivir, and another drug that I'm always butcher the name because I can't ever get it quite right, but it's tocilizumab, which is an IL-6.
Just rolls off the tongue. Just rolls off the tongue.
So, and then convalescent plasma. So those are the things
Right.
that they kind of looked at. And so their recommendations, and the reason why, you know, in medicine, a lot of what we do is evidence-based. You know, we want to have evidence and clinical trials that support the use of medicines and recommendations that we give to other physicians, you know, out in the community and elsewhere. So we want to be able to say that, one, the treatment that we're offering is safe, because safety is of utmost importance. And then two, that it's effective and provides a benefit. And so everything we do in medicine is risk benefit. And I tell that to my patients all the time. It could be as minimal as me giving you an antibiotic to treat something versus me recommending a surgery, you know, to treat something else. I always sit down with them and I say, look, everything is a risk benefit, and that you just got to weigh it and see which one weighs more. And so with a lot of these medicines, we don't know enough about it, and there's enough risk associated with it, especially the hydrochloroquine and the azithromycin, that, again, and this is just my personal standpoint, so, you know, don't quote, this is not necessarily the stance of people I work with or of the community as a whole. I think you have to weigh it really carefully. These medications have potential side effects with prolonging the QT interval of the heart and affecting conduction and leading to arrhythmias and things like that. And then, so you, again, so I don't know where, I don't think we're much closer with some of those medicines. Now, what we are seeing is that some of the trials that were being done in Chicago with remdesivir, which is that antiviral that was being looked at for SARS-CoV-2. It had also been used for Ebola in the past. They are actually seeing that patients are responding and having good outcomes. Now, the criticism to the way that their trial, because again, we're all evidence-based, we like clinical trials, we like double-blinded placebo-controlled trials. There was no placebo. And so you don't have anything to compare it to. So that's kind of the criticism of some of those trials, but the numbers look promising. And so that may be something that we're going to see really recommended in the future. And then obviously the convalescent plasma, assuming that the person who's receiving it has been typed and screened and it's, you know, it's typed appropriately, it's a relatively low risk. I mean, it's the same kind of risk that you would get with receiving any other kind of blood product. So I think that's where we are with treatment.
So Tim asks a very good question. He says, Dr. Saavedra, since you're on the subject of medicines, do you think there will be an absolute cure / vaccine for COVID-19, or will this just be something that we live with in our world for a very long time?
So that's a really good question. I hope that we will have a vaccine available. I don't think it's going to be anytime soon. I do, you know, with vaccine development, it takes time. It takes time to get it developed, to test its efficacy, to test its safety. And so a lot of people kind of usually use the time frame of a year to 18 months. And so I would imagine if, you know, we have a lot of incredible scientists and researchers who are working on this a lot. Maybe by 2021, we'll have something available that's been validated. I do think this is something that we probably will be living with for I don't want to say forever, but for an extended period of time. Now, again, the hope is that over time, if more and more people have become exposed to it and have developed immunity to it, at some point you will develop herd immunity. You know, we're not at that point yet. You have to have a very large number of your population have immunity in order for you to be able to kind of use that concept. But I think moving forward, if anything, if we learn anything from this entire pandemic, I think one, it's gonna force us to kind of have things in place to maybe act faster, you know, if something like this happens again. But not just that, I think it's gonna change our behaviors, I believe. And I say that with simple things: not going to work when you're sick, not sending your kids to school if they're sick, not going, you know, I know sometimes people are like, well, I really want to go to this event even though I'm feeling terrible. Don't do that. You stay home because you don't want to potentially expose whatever you could have to a lot of other people. And then I think we're going to start to see common things that I think we take for granted, but like, you know, man, the fact that we've had to really reinforce washing your hands during all of this, like, come on, guys, we should have been
Optimum. And so we are crystal clear, Doc. The optimum time to wash your hands with soap is approximately how many seconds?
It's 20 seconds.
Right. So one of our mutual friends sings songs in her head for the 20 seconds, and I've kind of started doing that to make sure that I get. So,
I mean, I was gonna tell you the song that we were singing. I mean, and every time I do like two little, I toss my hair back, check my nails. Sing it twice. You got your 20 seconds.
So if you're tuning in, we're almost to the halfway mark of this conversation. This is a Geaux Rouge webinar with Dr. Tatiana from the Baton Rouge Clinic. She is a physician of infectious diseases. I am screening the Facebook for questions. Kimberly had a question. She had to leave, but I will try to get this on so she can hear it. Kimberly had a question because she knows someone who was diagnosed with epilepsy, and she wanted to know that, to your knowledge, is epilepsy a high-risk disease or disorder?
So the high-risk medical conditions that we know for sure, they're primarily cardiac, so heart disease, underlying heart disease, that can involve like high blood pressure, a history of heart failure, a history of coronary artery disease, diabetes. I think diabetes is probably one of our biggest ones. You know, people don't, or if you don't have a family member who is diabetic and you've never really been around diabetes, I don't think people understand that diabetes is an immunosuppressed state. And so diabetes is definitely up on that list. And then patients who have underlying lung disease, and you know, because this is a virus, it's a respiratory virus, it attacks the lungs. If you have underlying issues with lung disease, you have a lower reserve. And so you could be potentially tipped over the edge a lot faster than someone who doesn't have any underlying lung disease. And then any kind of condition that puts you in a state where your immune system is compromised. And so that could involve people like who have HIV, or people who have immunodeficiencies for another reason, people undergoing treatment for cancer or other malignant, you know, things like that. Or even people who have rheumatological diseases and are on immunosuppressives to kind of control their disease process. As far as I know, epilepsy, I don't believe is kind of listed on one of the higher risk, but definitely I would say the ones that you kind of have to be on the lookout for: heart disease, diabetes, lung disease, and then anybody who's immunosuppressed or compromised in another way.
Changing gears a little bit, it seems like the CDC issues guidelines that sometimes modify or change. And it's been a little bit since we last talked. Any major updates from the CDC that we need to know about?
So yeah, they keep changing. I can't check it fast enough.
Right.
From our standpoint, one of the big changes that's occurred has been for healthcare workers. So before, because we get a lot of questions of a healthcare worker who may be tested positive for COVID and when can they return to work? And before, because we were so limited on testing and that was kind of the limiting factor, we were telling our healthcare workers that once you were fever free without taking medicine for 3 days, your respiratory symptoms had improved and at least 7 days had passed from when your symptoms started, at that point in time, you could return to work, but you're probably still going to wear a mask for a while just in case you're potentially shedding the virus. Well, the CDC completely changed that. I believe it was on the 13th, April 13th. Now what they're recommending is if we know that a person tested positive for COVID and they are a healthcare worker, now what they want, because there's more available testing out there, the 3 days of no fever still applies. So 3 days of no fever without any medicines, respiratory symptoms improved, but now you need to have 2 negative PCR tests before you can return to work. And again, that caveat still remains that even when you do return to work, you need to be wearing a mask, and that needs to happen for probably 14 days, even after you go. And then even limit your exposures to, like, you know, if you're working with cancer patients and things like that, probably avoiding that area for a while. So that's a big one where the things have changed a bit. I think the other things, and again, I haven't looked at it today to see if there's been any updates, but one of the things that they had been modified a fair amount was using protective personal equipment or personal protective equipment, PPE, for healthcare workers because there was such a shortage. I think some of that has improved. And so I think they're still kind of trying to be very conservative with our equipment and trying to reuse things that we can safely reuse. But those, I think, have been the big things. And then obviously from IDSA, the treatments that people are looking into with clinical trials.
So one of the things that came up yesterday for me, Doc, was I put on a small blood drive at Sullivan's, and I had several people that were recovering or had recovered from COVID-19, and they wanted to donate plasma. They wanted to donate plasma for convalescent plasma purposes or for antibody purposes.
Right.
And they were asking, when can I donate again? The phlebotomist with the blood, the Our Lady of the Lake Blood Center services, they were kind of saying, look, you know, in 29 days, 28, 29 days, you should test. If you test negative, we're still going to want something from your doctor.
Right.
But that's kind of the kind of canned answer, so to speak, was 28, 29 days of when you can donate blood. There is, and I did want to say this since we're talking, there is a high need for blood right now, right?
Oh yeah, there's a huge need for blood right now.
Right. So in terms of screening, I guess that's the question I had for you, which since you're the physician of infectious diseases, you would be a good person to answer this. Is it a risk to donate blood right now?
That's a good question. I don't think it is. I mean, okay, so I'll put it to you this way. The majority of the time, whenever you donate blood, it does get screened for most things, right? So we do screenings for HIV, you do screenings for hepatitis, you even do screenings for syphilis and other things like that. Those are kind of like routine screens that most blood gets screened for. I don't know if it's universal that they're screening. I actually don't know the answer to this, but I don't know if they are doing like molecular testing for COVID on blood. I have no idea. the way we've been primarily testing for COVID is through either like an oral pharyngeal or nasal pharyngeal swab, looking for the actual virus. Looking at kind of the plasma donation side of it, if we look at their kind of criteria for when you can donate, one of them does say either you have a negative COVID screen. So if someone has been positive, they want a negative COVID test before you can give blood, or a molecular test from the blood. I just don't know who's actively doing that. I think overall though, if you are, I'll put it to you this way. People who tend to shed the most amount of virus are those that are truly symptomatic, okay? The more symptomatic you are, the higher your viral load is usually at that time, and the higher risk of like infecting someone else's. So if you're asymptomatic and you're going to donate blood, even if you were shedding some of the virus, I think the numbers would be pretty, low in comparison to someone who was, having a fair amount of symptoms. So I think overall, because the need for blood is so high here in the community, that as long as you are otherwise healthy, I would encourage people to go donate.
So yesterday they screened, and it was a very safe process. They had a big giant bus. They didn't let more than 3 donors on the bus at a time, and there was certainly enough distancing between them.
Right.
They did a very thorough screening of questions. They checked iron content. They checked vitals. They asked what seemed to be the right questions.
Yeah.
So I felt, in terms of giving blood, I felt like it was pretty safe.
Oh yeah.
So I had a high iron content, but they said that I would feel better after donating blood, and I got to tell you, kind of did. So we got some time left. Again, you're listening to Dr. Tatiana from the Baton Rouge Clinic. We are fielding questions on Facebook Live. So if you've got questions out there that don't necessarily involve what food group a hot dog or lasagna involves with, Adonica, please shoot them out there and we'll answer them. Can you go over, and I know we've done this in part 1 of our conversation, you went over some common sense things to think about this virus. I think it would be valuable to go over that again. What is COVID-19? What are things you need to be aware of and thinking about?
Okay, so COVID-19 is caused by a novel beta coronavirus. Coronaviruses have been around for a very long time. If you look at kind of run-of-the-mill kind of colds and things like that a lot of kids get, those have been due to coronavirus for as long as we can remember. So they've been around for a long time. This particular virus did initiate, or we believe started in Wuhan, China, at one of those wet markets. And initially it did originate from bats. And at some point there was an intermediate animal host. And then it went from animal to human. And from there, we've been dealing with human to human transmission. Different viruses are spread in different ways. This particular one is spread through droplets. And so it's primarily through the respiratory route. So you can also, potentially contract it through household surfaces or contact surfaces. But the biggest one is when you cough or you sneeze and you are expelling, respiratory droplets, then those are kind of in the air. And if somebody else is nearby or close to you and they inhale it, then they're inhaling that virus. Most concerning, and I think I mentioned it not long ago about kind of infectivity or how infectious you are. The more symptomatic you are, the thought process is the higher your viral load is or viral count is. And so maybe you're a little bit more infectious. So again, that's why we have been recommending, if you are sick, stay home, don't go to work, potentially exposing. I mean, I know now everything is kind of different and everybody's at home, but using this moving forward, if things do start to slowly reopen, kind of keeping this in the back of your mind. When you cough or you sneeze, go into your elbow. Try not to go directly into your hand. If you do cough or sneeze into your hand, immediately go wash your hands or use a hand sanitizer or something else. Same goes, we talked about, Franz, you've done better about touching your face this time.
Did you notice?
I did notice. I caught you a few times kind of doing this, but it was much better than last time.
So, it is killing me. It is a nervous tick of mine. And I mean, candidly, it's a nervous tick of mine to fiddle with my chin when I'm either thinking or trying to deal with being nervous. And so I am literally actively doing this right now so that I don't grab. It's hard. It's an adjustment. So
touching your face, that's a big one. Because, the more you touch your nose, your mouth, your eyes, if you are infected, then you're just kind of spreading things, and then you go and touch somebody else or shake somebody's hand, then it's another way of spreading it. And then the same goes with contact surfaces. So, one of the things I've been telling our patients that come in who are either have tested positive or we were concerned about them being positive and they were living with their spouse or their family members, I tell them, look, I know y'all are probably going to do your best to try to keep the person who's sick kind of isolated a little bit more from the rest of the family to protect everybody else. But don't forget to wipe off commonly used surfaces. And so keyboards are disgusting. Cell phones are disgusting. Doorknobs are disgusting. I mean,
I was talking to the phlebotomist yesterday about our last conversation about cell phones. And it was very funny. And I was like, she described cell phones as like this cesspool of germs and grossness. And they were all like, yeah, they are. So,
I mean, that's the nice thing about being in the hospital. Like, they have a lot of the cavi wipes and all these different wipes that you can use that are like medical grade, and so after almost every patient encounter, I would grab one and I'll do it with my stethoscope. I always wipe down my stethoscope, but then you get in the habit of wiping down your phone as well.
So I'm keeping something in my car because I want to wipe down my wheel. For whatever reason, and door handles are starting to really, I can't explain it, but door handles are starting to give me the heebie-jeebies. Tim with another good question. Tim writes, with a new focus on social distancing and LSU fans being LSU fans, can you imagine a day, Doc, where over 100,000 people being crowded together again will happen, given our renewed awareness of how viruses are spread and how serious this one is? That's a tough question for the doc.
It is a tough question. Thanks, Tim. I'm kidding. I don't know. I mean, I really, I've said this to several people that I don't know that life as we know it will ever go back to what was normal for us. Not to say that it's not going to come close. I just think that having lived through this now, I mean, think about the last time we had a pandemic like this was over 100 years ago in 1918. And so I would imagine that for quite some time, things are going to be different until people tend to forget about it. You know what I mean? And I don't know how long it's going to take for that to happen. I think people are going to be more mindful. I don't know if it's going to become more of a socially acceptable thing to be wearing masks out more. I don't know. I don't know the answer to that. I don't know. Maybe people will start, it'll become a thing to have your LSU mask on when you go to the game. I don't know. Maybe I should start. Maybe I should get on
an LSU mask. I have an LSU mask. Well, I'm a big fan of cognitive psychology. Not necessarily infectious diseases, but I use a lot of it in jury work. And there is a principle in psychology, and it stems from World War II, where if you were in the blast radius of an explosion, you kind of build up a psychological weird immunity to hazard. And the idea is if you survive the COVID-19 scare without getting sick, the risk is you will not take it as seriously because it was it was a near miss versus if you
But
caught
it
it and
didn't
you survived.
directly affect you. It didn't. Yeah.
Right.
Yeah.
Yeah. So,
Absolutely. Yeah.
so there are, you know, and Tim, I'll say this. I have predicted based on nothing other than just random prediction. I think the way we will reintegrate sports will be that sports will happen at some point, but it may be like the NCAA doesn't let people attend for a little while.
Yeah.
It may be that we just have to make adjustments. I'm okay. Look, guys, I'm okay with a world where we have to wear masks for a little while. I'm okay with a world that we just wear masks because it's the smart and safe thing to do. Let's see, what else can we talk about? There was a question from Janelle. And Janelle, I'm not sure if I'm going to get the full grasp of your question, but I'm going to ask it because I think I know what you're asking. In terms of when we get a vaccine, what are the risks associated with taking? Okay, because I'm not an anti-vaxxer. I know you're not an anti-vaxxer, Doc. What are the risks associated with taking a vax, and who will likely be the first to take this vaccination when it comes out?
So I don't know. I mean, I think if you think about general risk with any vaccine, the risks are actually pretty low. And again, this is medicine. And so it's all about risk benefit. And I use that to say, and I bring this up because I am not an anti-vaxxer. I am very much pro-vaccines. And you know what? Something that kind of got forgotten for a little bit was this whole measles outbreak that we had right before COVID started, and a lot of that was because people were not vaccinating their kids against the measles, and we had a lot of kids die. People don't remember that these viruses kill people, but they don't kill people anymore because there's a vaccine for them.
Right.
So what I want people to remember is now think about what we're going through right now. We are living in a world with COVID. We don't have a vaccine for it. And we're seeing a lot of our loved ones die or get critically ill and stay in the hospital for weeks at a time. So when that vaccine becomes available and it is deemed that it is safe and effective, remember this time, because I don't know how else to kind of like bring it back to people that vaccines are not a bad thing. We're not giving them to make money. I don't get any money. I don't get sponsored to like say that vaccines are a good thing. I do it because I know it's the right thing to do. And I know that it protects our kids and our community and our population that can't take vaccines for one reason or another. So I vaccinate my kids because I have friends who can't vaccinate theirs. So for the most part, vaccines are very safe. Sometimes you can get a local injection site reaction, a little soreness in the area. Every now and then you might have some crazy reaction to like whatever the formulation is. You know, for a while there were, you know, eggs in some of the vaccinations, and people who had allergies to eggs couldn't get it. And so there are things like that. But for the most part, very few risk and side effects associated with them. In terms of who will be getting them first, I don't know. I would imagine that they probably make it universal to where they offer it to anybody. But I would, you know, if we're really trying to focus on those patients that are highest risk, then they may start saying, okay, 60 and older, you're going to be the first wave that gets it. Or people with underlying chronic medical conditions, you're going to be the first wave to get it. And then it'll kind of trickle down until, because again, you need to make sure that you have enough for the masses. And so if it's, you know, if there's not enough in production to vaccinate everybody universally, then I think you're going to have to do it in groups. How they're going to decide to do that, I don't know. But
so we got about 10 minutes left, guys. I am with Dr. Tatiana from the Baton Rouge Clinic. She is a physician of infectious diseases. In our 10 minutes left, I will ask any questions you guys have if you're on the Facebook Live thread. Tim wrote, "Oh, great point. How infuriating is it for you to know that there are anti-vaxxers out there?" We're not going to go there, Tim. We only have 10 minutes. I had a question about ventilators. I know that there was a big concern about us not having enough ventilators in treatment facilities. Any updates on how we're doing on ventilators? Have there been any changes to what constitutes a ventilator for purposes of treatment?
So, and again, I can't speak too much to this because I have not been in the hospital taking care of inpatients, but I can tell you from what I, get reports from the lake and the general and things like that to kind of know what the situation is in those places. As far as I know, we are not in a place where we're having shortages here in Baton Rouge.
Good.
Now, the thing about this disease is, it can lead to ARDS, which is the acute respiratory distress syndrome. And that ARDS is a bad thing. I mean, I treated a lot of people who had ARDS when I was a resident, and even as a fellow, I saw a lot of patients who had that. And there's a lot of, and this is more in the critical care realm. And gosh, shout out to all of our ICU teams that are out there working their tails off taking care of these patients, because it's hard work. So thank you. But they have different strategies to use, and even positioning. So I don't know if y'all have ever seen on the news, sometimes, I mean, it was like a month ago, they were showing some of the footage in Italy's ICUs, and you saw patients were prone. So they weren't on their back, but they were on their stomach. So there are different strategies to use that help improve oxygenation and help improve ventilation. The problem with this virus, when it leads to ARDS, is that some of these patients end up on the ventilator for a long time. And so it's not necessarily so much that the shortage is, it's more because you just can't get people off of it. So you're having someone stay on that one ventilator for a super extended period of time. And that's where a lot of the shortages come in. It's not like you're having, hundreds and hundreds and hundreds of people coming in that need to be on the ventilator. And there was some new data, and I'm not going to go into too much detail about it because I can't really support it. I haven't done a lot of reading on it. But there was a thought process that came up not long ago that maybe initially we were trying to put people on ventilators sooner than we needed to. And maybe we allowed some level of lower oxygen levels in patients before opting to put them on. And so I don't know where the stance of that has been, because I haven't really read up on that lately. But I think here in Baton Rouge, we're okay. But
Good.
Again, we're also, I think we've done a decent job of following our orders and, staying at home and social distancing and all of those things. And I don't think right now is the time to let up on it. What I don't want to happen is people to get this false sense of security that, oh, things are really starting to improve, we don't need to kind of worry about it anymore. I think we need to kind of have this, a little bit of fear in us.
Fear's a good thing. Fear is a good thing.
But I think there is definitely light at the end of the tunnel. I just want us to kind of still be good about what we're supposed to be doing, because I do want us to kind of really continue to flatten that and not start to have a second spike in things.
So I think we have time for one more question, and somebody private messaged me this, Doc. Any updates on transferability of the COVID-19 with regard to pets? And specifically what she is asking is it safe to walk your dog right now? And if we have any updates on whether or not animals can transfer, or for that matter, what's the probability, whatever words you want to use, of getting it from an animal?
From an animal. So the one thing that I've learned through all this is that coronavirus is a common, it was a virus that's seen in animals. So one of the labs that we're using is the vet school, because they have the capabilities to do testing for this, because they test their animals for coronavirus. Maybe not this particular one, but this is something that is not new to them with regards to coronavirus in animals. I don't know that there's ever really been a big concern about transferring it from human to dog or dog to human. So no, walk your puppy. The puppy needs it.
Humans, I got to tell you, and this is my non-medical opinion here. Social distance walking, getting out of your house, getting some, vitamin D.
Mm-hmm.
Good thing.
a good thing.
Eric writes, I heard of the Chinese study that indicated COVID-19 interferes with the red blood cells' capacity to carry oxygen. Is there any other studies that bear on that issue? Good question, Eric. Eric's an attorney. Good question.
I don't know.
Okay.
I'd have to do a literature search to see.
And we talked about this last time. Chinese studies, because one of the big hot debates in my cigar chat room Zoom sessions is the validity of a study from China. Because on the one hand, some of us argue, well, look, this is a country that has high volume, and they kind of were ahead of us in a lot of the things that they were seeing. And then there's the other faction that says, you can't trust anything from China. I'm not asking you to comment on the socio-political side of China. But as a piggyback to Eric's question, are you guys seeing literature come out of China that y'all can look at it and say, this looks like good science?
Yeah, I mean, now mind you that whenever we, kind of going back to us being very much evidence-based people and relying on studies and case reports and things like that to kind of continue to learn about different processes, you have to you got to keep in mind that a lot of the data that's come out has involved small numbers, right? So most of the papers I've looked at, while the information in them seems fairly reliable and very interesting, the problem is that it's all very small numbers. And so you don't know how that's going to pan out, or if you can really extrapolate that data to a larger patient population. But I do think it gives us a good starting place on things to think about. So some of the things I've been trying, and I try mostly IDSA, again, ID nerd here. I go to their website and they have kind of like the most up-to-date journal articles, regarding COVID. And so some of the ones I was reading on was how soon after being infected do you develop the antibodies? Like, what's the time frame and testing for those? Or people who were shedding virus for an extended period of time, like what was the time frame? And another thing that's come up, and initially we thought that this was a fairly short illness, or I shouldn't say short, because 2 weeks is not super short, but we usually told patients, 2 weeks is usually about the time that people start to get better. Well, I have seen several patients who are beyond that 2-week time frame who are still having symptoms. And so I'm looking to some of the Chinese literature to say, hey, in your patient population, did you have a lot of patients that went beyond 14 days truly still symptomatic? But again, I think the problem is that the numbers are so low in some of those papers that it's really hard to know how to interpret it.
Right. So we got 2 minutes left, Doc. Anything to close out with before we cut this wonderful chat?
No, I mean, I think just thank you for having me on as always. But I just keep doing what we're being asked to do, because I think it is working. And I know it's incredibly frustrating to not be able to go out and see your friends and family and do the things that we would normally do. And I know my kids are getting stir crazy, and I can only imagine. I mean, at least I get to come to work and kind of get my mind off of I don't get my mind off of it, but it's in a different way.
But I will say, for those who don't know, I'm at my law office right now, and I hide at my law office because there's nobody in my office. It's very quiet. It's very peaceful. So to get out of the house for me is to go to my office to do some work, to do some Geaux Rouge stuff. So there is a therapeutic side of getting out of the house and going somewhere that is safe. So
and look, because and I'm going to bring up my group 3 girls again. And I love one of my favorite things about all of this has been seeing people being outside. I mean, social distancing, they've been good about it, but like I've seen so many more kids and adults riding bikes as families, like they kind of go on their little family bike ride around the neighborhood, people walking their dogs, all these things. I think if anything, maybe this is going to make us appreciate, outside a little bit more, and hopefully our kids aren't going to be so stuck on video games and other things, and kind of enjoy all the things that, being a kid of the 80s, you get on your bike and you disappear in the morning and you come home at night when the lights were out, or when it got dark. But so I think that's been one of my favorite things. And self-care is super important. So if you feel yourself overwhelmed with all of this, which I'll admit, I mean, on a daily basis, I get a little overwhelmed with everything. Find a way to kind of take care of yourself, even if that's by going for a run, or FaceTiming with a friend, or setting up a Zoom chat with girlfriends that you haven't seen in a while. Whatever it takes, just do it, because I think our mental health is definitely something that's gonna we're gonna see some issues with that, I think, long term after all of this is done.
Outstanding. So you guys have been listening to Dr. Tatiana Saavedra from the Baton Rouge Clinic. She is a physician of infectious diseases. I will post this webinar on the Geaux Rouge website, www.geauxrouge.com. Doc, thank you. We'll definitely do this again, maybe in a couple of weeks. Be safe. Love you to death. And we will talk to you soon.
Franz. Bye.
All right.